You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 23rd, 2018. This week, post-cardiac surgery atrial fib, radial versus ulnar approach to heart cath, aspirin and heart failure, VTE prevention, and low-fat versus low-carb diets. First topic is post-cardiac surgery atrial fibrillation. AF that occurs after cardiac surgery may be one of medicine's most pesky problems. An article published recently in JACC confirms hundreds of studies on post-cardiac surgery AFib. This most recent one comes from the authors of the Excel trial. Excel was an RCT comparing coronary artery bypass surgery versus PCI in patients with left main disease. Now, this was a post hoc analysis, and the results were as follows. AF occurred in 18% of the surgery group and almost none of the PCI group. Only one patient in the PCI group had atrial fib, which that's not a surprise. New onset AFib associated with longer hospital stay and more bleeding at 30 days. And post-cardiac surgery AFib was a strong predictor at 3 years of major adverse cardiac events. And we should not overinterpret this post hoc analysis. There were small numbers of events. For instance, only 10 patients in the AFib group had strokes and follow-up. So if you have small numbers, it's hard to make predictions. And the authors did not know if patients had AFib before the surgery, and most importantly, they did not collect data on AFib recurrence during follow-up. So I agree with Dr. John Pacini, who was quoted in a news article and said that this is a call to arms to do studies on how to manage these patients. For instance, a well-conducted RCT, the rate versus rhythm control trial, which was published in New England Journal of Medicine, and I'll link to it below the podcast, showed no net clinical advantage with either a rate or rhythm control strategy in post-cardiac surgery AFib. So in this important trial, the anticoagulation decision was left up to the treating physician. I would love to see a trial looking at anticoagulation versus antiplatelets in these patients because it's a question I get asked all the time. I don't know which is the right answer. It would be a great thing to study. Second topic, radial versus ulnar approach to heart cath. Now, the thing that needs to be said before discussing the two arm approaches is that the move away from doing interventions through the leg has been one of the most striking and beneficial changes I have lived through in my cardiology career. Gosh, there was harm from putting big sheaths in the femoral artery in anticoagulated patients. A group of Australian authors published a meta-analysis of 6 trials that compared radial versus ulnar approach to heart cath. The journal Cath and Cardiovascular Interventions published a study, and the authors found no difference in major adverse cardiac events with either approach, but complications were higher in the ulnar approach. The odds ratio was 2.6. Most of the complications related to hemostasis, and the most feared complication, arterial occlusions, did not differ in the two groups. One of my interventional partners told me that they just reviewed our cases here and found that ulnar complications were definitely higher. Dr. Sunil Rao, who was quoted in a news story, mentioned that ultrasound-guided access would likely reduce ulnar complications. And I don't do coronary angiography, but I can no longer imagine accessing vessels without ultrasound guidance. Ultrasound also is a beautiful development. I love seeing where that needle goes. You can aim it right into the target, and I can't believe we used to stick blood vessels blindly. Third topic is aspirin use in heart failure. Now, most clinicians, me included, are attached to the use of aspirin. Here's what I mean. You're in clinic, the patient has heart failure, you scan the medicine list, and if there's no antithrombotic drug, you worry. You can't help it, it's natural. We've been programmed to think patients with heart disease need quote-unquote protection. As a commenter noted in a news story, patients are naked without aspirin. But it turns out that the evidence for long-term aspirin use is inconclusive. And this is the background for a large Danish cohort study looking at the safety and effectiveness of aspirin in patients with heart failure without atrial fib. Now, the Danish investigators can use their nationwide registry of medical records and also pharmacy records to do these sorts of large, non-randomized studies. For this particular study, the authors screened about 60,000 patients who were admitted for heart failure. They then excluded events in the first 90 days after discharge to remove confounding of previous aspirin users. The final sample included 12,000 patients, and of those, they propensity matched 3,800 aspirin users to 3,800 non-aspirin users. Now, about a third of the patients had ischemic heart disease. And even with that, there was no difference in the composite outcome of major events. No difference between aspirin use and non-aspirin use. And aspirin use was associated with an increased risk of both MI and increased risk of heart failure readmission. Perhaps the most interesting part of this story is Professor Cleland's editorial. It's a must-read. I'll summarize some of his take-home points. First, and I didn't know this, there is no RCT showing that aspirin given for longer than 28 days reduces cardiovascular mortality after MI. He also noted the results of meta-analysis have been driven by small and outrageously positive trials, and that, he suggests, brings into play publication bias. He also says that RCTs do not suggest that stopping aspirin from patients with stable coronary artery disease is associated with risk and may be beneficial. And I think that's an important point because one of the big things is people are afraid to stop aspirin. And also, he puts out this potentially interesting theory that not all vascular occlusion is primarily thrombotic. There is some evidence that hemorrhage into the plaque may often be the primary event. And if that's true, you could see how aspirin could plausibly increase MI. He also notes that subgroup analysis of the landmark trials from which the guidelines are based also suggests that aspirin may detract from the benefits of ACE inhibition or mineralocorticoid antagonist. So international guidelines have not reached a recommendation on the use of aspirin in patients with heart failure. This, Cleland points out, makes it reasonable to do an RCT to ensure that aspirin is either given or withheld based on the evidence. And I find these revelations on aspirin quite striking because doctors and patients alike both feel like it's beneficial and almost feel, like I said, attached to the use of aspirin. But the evidence, again, not conclusive. The fourth topic today is about venous thromboembolism prevention. Now, I use aspirin after I do SVT catheter ablation or other EP procedures when patients aren't on anticoagulants to prevent VTE. It's what we did back in the 1990s when I started training, and it became a habit. Now, sometimes I wonder whether aspirin does anything, but just makes us feel better. Now, hip and knee replacements, orthopedic surgery confer a significant risk of post-op VTE, and guidelines recommend VTE prophylaxis with drugs. Aspirin is an inexpensive and widely available drug. And clinical trials and meta-analysis have suggested that aspirin may be effective for prevention of VTE, but it's not been tested against direct-acting oral anticoagulants. The EPCAT-2 trial, which is published in New England Journal of Medicine, was a comparison of aspirin versus rivaroxaban at 10 milligrams for either 9 to 30 days, 9 for knee replacement and 30 for hip replacement. All patients in this trial had 5 days of low-dose rivaroxaban after surgery, then half went to aspirin 81 and the other half to the rivaroxaban 10. And the rates of VTE were nearly identical, 0.64 versus 0.7, obviously non-inferiority for aspirin. There was also similar and low rates of bleeding in the two groups. An editorialist noted that relatively few patients with high risk, like those with previous VTE or morbid obesity or cancer, underwent randomization, so can't really apply these findings to super high-risk patients. Another commenter in the news story noted that the post-op period of 5 days of rivaroxaban is not a common practice, so that's also an unusual thing about this trial. Nonetheless, this trial kind of established a simple, inexpensive way to prevent VTE after orthopedic surgery. And I highlight it because a lot of people have orthopedic surgery, and I also was surprised at how well aspirin fared against the real anticoagulant. Fifth and final topic today is low-fat or low-carb diet for weight loss. Now, since I take care of atrial fibrillation, I spend a lot of time in the clinic talking to people about weight loss. And after I've given my talk, patients often ask, okay, doc, what is the best diet? Is it low-carb or low-fat? And to be honest, I struggle with that question. That was the topic of a recent large nutritional study from Stanford authors and published in JAMA. And it studied low-fat or low-carb diet and looked at weight loss. Investigators took overweight volunteers and they randomized them to two pragmatic types of dietary plans. One plan was priority was given to reducing edible oils, fatty meats, whole-fat dairy. So that's the low-fat plan. The other group was advised to reduce cereals, grains, rice, starchy vegetables, and that's the low-carbohydrate plan. A sub-hypothesis of this parallel group trial was whether or not there was a genotype and a diet interaction. They looked at 3 single nucleotide polymorphisms, or whether or not there was an insulin resistance and dietary interactions. And the findings, both groups lost on average about 5 to 6 kilograms, and it was not statistically significant. And the authors found no interaction with either genotype or insulin resistance. Of course, it's a nutrition study, so it has plenty of limitations, and the authors listed 6 limitations in the discussion section. Now, I think the authors' comments are correct. They note that when equal emphasis is given to high dietary quality for both low-fat and low-carbohydrate eating plans, it isn't helpful to preferentially direct an individual with high insulin secretion status who is seeking weight loss to follow a lower carbohydrate eating plan instead of a lower fat eating plan. I realize that there are very smart people on both sides of this nutrition debate, and future studies may give us more definitive answers about the absolute best diet. But this study sort of helps me because at least I can tell patients that here's a trial that looks at simple, pragmatic plans to reduce either low-quality fats or low-quality carbs, and they both produce equal amounts of weight loss. That's good to know, and it's good to cite the studies like this. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.